Well, good day, esteemed colleagues and participants. On behalf of the cardiology program at University of Antioquia, it is a great honor to welcome you to another session in our cardiology approaches series. We are privileged to have with us today Dr. Giuseppe Rosano, who will be discussing a critical topic in cardiology: optimal medical therapy versus revascularization in chronic coronary syndromes. Dr. Rosano is a leading authority in cardiology, former president of Heart Failure Association, and currently serves as a consultant cardiologist and professor at St. George's University Medical School in London. His insights and expertise will guide us through the complexities of this crucial debate. We are grateful to have him share his knowledge with us today. It is my privilege to now invite Dr. Giuseppe to take the floor.
Thank you. Thank you very much for the invitation. It's a privilege to be with you, albeit virtually today. What I'll do in the next 45 minutes is to discuss the balance that we have to take when we approach patients with ischemic heart disease and think about medical therapy or PCI. And when we think at ischemic heart disease, this is what we usually think, and what many of the cardiologists think, at a clogged pipe that needs to be opened up. So, the approach to ischemic heart disease for the past 40 years, has been the one of finding the stenosis and fixing the coronary obstructions. But fixing sometimes may have goes a bit too far, as in this case that was reported in JACT in 2010 with 64 stents, and you can see that basically the LAD, the LCX, the marginal, and the RCA were all taken, and you need to ask yourself whether there's any reason for this extensive implant of stenting that in many cases, like in this one on the LAD, prejudice the possibility of implanting any further graft in a patient that has already received coronary vascularization. So, what is important is that we also have to realize that chest pain is not solely related to obstructive coronary artery disease. When we get patients with chest pain, we have patients who have non-cardiac chest pain, we have patients who have cardiac pain that is not ischemic, so it can be an inappropriate pain perception, it can be pericardial pain, and then the cardiac ischemic can be related to inflammation, can be related to endothelial dysfunction, spasm, microvascular angina, or can be due to an obstruction. Now, the best way to see what is the epidemiology of ischemic heart disease and microvascular dysfunction came from the ischemia trial. I will get into details in the ischemia trial later, but what is important is that these were nearly 6,000 patients who had angina was severe enough to have a provocative test that was positive for inducible myocardial ischemia. So these were patients with angina and evidence of myocardial ischemia that then underwent on a CTCA. The CTCA was mostly performed because patients were due to be randomized to medical therapy versus a coronary intervention, and therefore there was a need to exclude left main disease. So what they found in these patients where there was severe angina, severe enough to proceed to coronary angiography, was that they found that in 20% of patients there was no obstructive arterial disease. Then there was another proportion of patients where the coronary atherosclerosis was even more limited. And then also we have to understand that non-obstructive coronary artery disease is as important as obstructive coronary artery disease because it is associated with a significant increase in major cardiovascular events and cardiovascular mortality. And you can see that the occurrence of events in patients with normal coronary arteries and angina is similar to that of those with diffuse non-obstructive coronary artery disease. Also, you can see here the curves. When you look here in blue at the asymptomatic, patients with with one vessel disease, two vessel disease, or three vessel disease have a progressively worse prognosis. But you can see also that in those patients with a non-obstructive arterial disease have a similar event rate of those with one, two, or three vessel disease, and those with normal coronary arteries have a significant worse prognosis than those who are completely asymptomatic. So the microcirculation is very important, is another important cause of angina. And we always think at this dichotomy between microvascular angina and obstructive angina. The microvascular angina is due to structural mechanisms in patients with that may be due to microembolization, intravascular plugging, perivascular fibrosis, capillary rarefaction, for example, what occurs in patients with hypertension, but also related to left ventricular hypertrophy, reduced diastolic time, and other conditions like amyloidosis, hypertrophic cardiomyopathy. But also we have to think that coronary artery disease and macro and microvascular angina may coexist in the same subject. And macrovascular angina is very important because, as you can see, the macrovascular bed is very extensive and is much bigger than the epicardial vessels. And you can see that also that it's the small vessels are very tiny, and sometimes even the red blood cells have to squeeze through the microcirculation in order to bring oxygenation. So when we look at ischemic heart disease, we have to look at patients with either stable coronary syndrome and acute coronary syndromes, and together with the presence of obstructive arterial disease, coronary disease that causes stable coronary syndromes, unstable angina, STEMI and STEMI, we have the two conditions of INOCA, the one of ischemia with no obstructive coronary artery disease, and MINOCA, that is the myocardial infarction with no obstructive coronary artery disease. So this is to give you a picture and to understand why medical therapy and interventional therapy are often complementary. Now, of course, when we look at the ischemia, we also have to think that we have ischemia may be related to the big coronary vessels with a flow-limiting stenosis, with endothelial dysfunction, and often when we get an endothelial dysfunction on epicardial coronary vessel, as demonstrated by Schackinger already in 2000, that is a site where after a few years we will have the development of coronary atherosclerosis. We can have also in angina due to vasospasm that occurs more frequently with a nocturnal angina or muscular breach, and but also microvascular dysfunction with spasm and inflammation, as I said earlier. Now, all of these effects have a direct effect on myocardial cells, and therefore they can affect the energy metabolism, some of the specific currents into the cells, but also inflammation, fibrosis, and production of radicals. Now, therefore, if we look at the angina today, angina is a combination, can be the result of patients with stable angina, vasospastic angina, microvascular angina, and the presence of a fixed atherosclerotic narrowing is only one of the part of the causes of the problem in patients with angina, and often the different pathologies, the different pathophysiology may overlap. Now, of course, when you think of ischemic heart disease, and if you think that it's only obstruction, then you may think that the best therapy is to open up the artery. And the open the open artery idea has always fascinated and led to many trials. And you can see these trials between 92 and 2014. I will show you the other ones later, where basically demonstrated no difference in terms of mortality, prevention of myocardial infarction between medical therapy and PCI. Of course, PCI has a good effect on as a short-term angina relief. That is, this is uncontroversial, and is always better than, has always been better than medical therapy. But this is limited for a short period of time, whilst there's there's a small difference on quality of life over long term, and there's no effect over long term on angina. Now, when we look at the stable coronary artery disease, the medical therapy and intervention, we see that there's no hint that there's any favor, any trial that may suggest that PCI is better than medical therapy. So medical therapy is always similar in terms of future cardiovascular events to PCI. As I said, the only advantage for PCI is the short-term benefit. But the short-term benefit, we have to ask ourselves whether the short-term benefit can be also psychological in nature. And these are very important results from the Orbiter study. In the Orbiter study, it's a study that was supported by the British Heart Foundation and the NIHR, and they randomized patients to either an angioplasty or to a sham operation. And basically, patients were either receiving the angioplasty or they were put asleep, had the sheets put in their groin, and then they didn't know whether they received the angioplasty or not. And in these patients, PCI did not increase the exercise time more than a placebo procedure. You can see that in terms of benefit, there was just a slight improvement of one class, better improvement of one class, but no significant and substantial benefit. And in terms of stability, you can see that also the effect on angina was similar. So we have to ask ourselves whether the short-term effects on PCI that we've seen in many trials can be also related to a sort of placebo effect on angina. Now, what is also important is that over time we have an improvement of methods, and some of the methods, and also for indications. And there has always been a suggestion that if you identify the correct patients for angioplasty, then you may get a benefit. And the FFR is now largely used to guide PCI. And this is the FAME study that supposedly suggested that the FFR-guided therapy was better than medical therapy. You can see the medical therapy here and the FFR-guided PCI that was the similar prognosis of those with no flow-limiting stenosis. I mean, this is what we always believe, but the primary endpoint was driven solely by urgent revascularization, and 52% of patients undergoing revascularization had no evidence of ischemia on ECG. and also negative markers for myocardial ischemia. So if you look at the difference over the overall duration of the study, so 2 and 6 years, you can see that there was no difference in between FFR-guided PCI and medical therapy on death from any cause, myocardial infarction, death of myocardial infarction, death from any cause, or cardiovascular death. So the only difference was this urgent revascularization, which occurred mostly during the first year. Now, so what can be achieved by optimal medical therapy in stable patient stable or coronary artery disease? And we know that the optimal medical therapy goes hand in hand with the improvement in stents technology. And we had all the different technology of stents that have evolved over time, but also medical therapy has evolved over time. And the COURAGE study was the first one to assess the effect of optimal medical therapy that included full dose of a statin, antiplatelets, and ACE inhibitors compared to PCI. And you can see that they demonstrated that the randomization to PCI plus optimal medical therapy or optimal medical therapy by itself were not different in terms of future cardiovascular events. And if you put together the data from PCI, from COURAGE, and also data from other larger studies like the BARI 2, and it is what they tend to suggest is that if you super-segment patients and you find patients where there's a higher risk, maybe you may find evidence of benefit. And therefore, it was they looked at patients with diabetes or prior MI, but there was no difference between the two procedures, medical therapy or PCI. As there was no difference in patients older age, high risk of angina, more extensive coronary artery disease, 3-vessel coronary artery disease, low ejection fraction, proximal LAD stenosis, or chronic kidney disease. Now, more recently, the ischemia study, which I showed you earlier, basically demonstrated what should guide our medical practice. I mean, if you take just a superficial reading of the study was negative, there was no benefit overall of 5 years between medical therapy and angioplasty. But what the trial told us is that it told us that you may get a benefit after 4 years, but you have to pay a price for that benefit, because at 6 months with PCI, there's an increased risk of events. So if you're willing to take the risk of the initial in the first 6 months of potential events, then you may have an improvement over long term, despite the fact that there's no benefit overall. Looking at the ischemia study, there was no difference in terms of cardiovascular death or MI in patients compared to conservative or invasive treatment. There was no difference in cardiovascular death, no difference in all-cause death. See, the two curves were absolutely superimposable. So there was no difference between angioplasty and medical therapy. And regarding the myocardial infarction, this is what led to the difference between in the primary endpoint. You see that you have more myocardial infarctions within the first year in those patients undergoing interventions, and a lower occurrence over long term, with the curves that starts to cross over at around 3 years. Now, but so there's no evidence of any benefit of or superiority of one over the other. But I think that we have to look more critically at our patients today. And it's the question is not either or. It's the question when is more appropriate to do a revascularization and when it's more appropriate to do medical therapy. There may be patients that have coronary artery disease, they start on medical therapy, they will be very well on medical therapy for many years, but then sooner or later they may need a revascularization because of the progression of the disease. There may be other patients that maybe are intercepted because of an acute coronary syndrome. There is a revascularization of the culprit artery, and then they will continue medical therapy. So there is the issue. This issue is not what is better, but is what is better for that patient at that time. And what is better for those patients is that regardless on whether they receive an revascularization or not, is that they have to take medications. Because you can see that even those patients that have received a revascularization, those taking all medical therapy had better prognosis than those who took none or one medication at all. Now, before getting more into medical therapy, I think we need to also to mention the Orbiter 2 trial. The Orbiter 2 trial was a trial that was conducted in patients with stable angina who were receiving little or no anti-anginal medications with objective evidence of ischemia. And these patients were randomized to receive either PCI or nothing. And of course, those that received PCI had a better efficacy on the reduction of anginal symptoms. I don't think that then you need to have a Nobel Prize to understand that study would have been positive. So in patients that you see with angina, that then do not take medications or just take very few medications, angioplasty works. I mean, and that is incontrovertible. But then it doesn't tell us whether that is better than medical therapy. And even if you get benefit from angioplasty, then you get restenosis. And you can see that the restenosis also has been in this prospective registry with more than 8,000 patients. You can see that there is an increase in the risk of angina well before 1 year, and that it differs with a different type of stents. But when we look at the ischemic heart disease, we have also to look at it as a tip of the iceberg. This is the iceberg with the heart below it. Then we look at the coronary arteries, and we only look at the surface of the problem because we look only at the coronary arteries. Then there is those patients with this diffuse atherosclerosis that they induce a reduction overall of coronary flow, and also those with coronary microvascular dysfunction. And it's also important to understand that the coronary microvascular dysfunction may occur on a different vessel or can be present by itself in patients with normal coronary arteries, but also can occur, and this is very important, in patients with coronary artery disease. And sometimes can occur on the same territory of a patient with coronary artery disease, or sometimes can occur in a different territory of and this explains you why sometimes patients, despite a successful angioplasty, they still continue to have angina, because you've solved the problem on the left anterior descending, let's say, and but then they still have microvascular angina because of a microvascular issue on a different artery or downstream to the same artery. So therefore, restenosis is not the sole cause of symptoms after PCI, is not the sole cause why PCI is not effective. And we have always to think at the presence of microvascular angina. This is how we should probably approach angina today, with a critical view at the results of the Orbit trial, at the results of Courage, and all other trials that have been conducted in patients with stable coronary artery disease. So if the angina is infrequent or acceptable with, say, that is 80% of our patients, you can need to start the optimal medical therapy, then see whether that patient fits the criteria of the ischemia trial and perform a CTCA, of course, exclude heart failure, and consider a CTCA. Then, of course, if the left main disease is demonstrated at the CTCA, then there is need of a coronary angiogram, and then decide what is the best approach. In those patients with daily or weekly angina, or those patients where the angina is just affecting too much the quality of life, then there is an indication for the use of angioplasty. What is important is that we don't have to tell patients this is the only solution. This is one of the solutions that we can be taking. But also we have to take into account that we have some preconcepts on the use of anti-ischemic treatments, because as for today there's no universal definition of which drug combination is optimal. As we from the ESC guidelines on chronic coronary syndromes, the anti-ischemic drug therapies might be adapted to patients' characteristics and preferences. And as we do for hypertension, as we now do for lipid-lowering therapy, the initial drug therapy for angina should consist in one or more anti-anginal drugs. So because anti-anginal drugs tend to have a complementary mode of action, and also we have to take into account the potential drug-to-drug interactions in patients who are co-administered. When we look at the indications for that come from the guidelines, we can see that there are 2 class 1 drugs, but we need to be very careful and read also in the text. Now, the short-acting nitrates, so the sublingual nitrates, are recommended for the immediate relief of angina, for that is a class 1B. Now, when you look at the treatment for beta blockers and calcium channel blockers, I mean, that you have to read the guidelines, because you may be misled if you look only at the table. The only reason why the beta blockers and the calcium channel blockers have been given a class 1 is because they are widely available and they are cheap. And this is clearly written in the guidelines. But if you look at the clinical trials, I mean, clinical trials with beta blockers have included 20, 30, 100 patients at the most. And if you consider those trials with other medications that I will show you later, you can see that they should be inadequate for today's standards. This is a review of all clinical trials that have been conducted in the past 50 years that we conducted together with Professor Ferrari and a few others. And basically, we couldn't find any study that demonstrated a difference in total exercise time of one treatment compared to the others. We looked at beta blockers, nitrates, calcium channel blockers, and metabolic therapy. And there was one study where metoprolol was superior to nifedipine on time to 1 millimeter of depression, but not on exercise time. And there was no evidence that one drug being superior to another and they were often equivalent. So when we look at benefit of the beta blocker, we believe that we have to give beta blockers to all patients. But looking at the events, looking at all the long-term trials with beta blockers, you see that there's no benefit in terms of survival. And if you look at the more recent data, because the beta blocker trials been conducted many years, many decades ago, If you look at the registries, and this is the REACH registry, you can see that there's no benefit, no significant benefit between those who take beta blockers or do not take beta blockers. You see that especially in for patients with coronary artery disease and risk factors only, then even the use of beta blockers may be even detrimental. So for long-term use, there's no benefit of beta blockers. This is a very important study that looked, coming from Denmark, where they looked at the use of beta blockers or no beta blockers use in patients with ischemic heart disease. And they found that there was no difference whatsoever, 1, 2, 3, 4, 5 years in all-cause mortality, cardiovascular death, recurrent MI, stroke, PCI, or CABG in patients receiving or not beta blockers. There was only for the first year, there was a benefit in the reduction of heart failure hospitalizations with the use of beta blockers. The other class of drug that is commonly used are the nitrates or the NO donors. And you see that there was, if anything, the studies point towards a detrimental effect of nitrates on events, and looking at all the long-term trials. And if you look at why these are the reasons for the lack of effect or long-term of the chronic nitrates is because they induce endothelial dysfunction, and in terms of and they may induce tolerance. And you can see that the long-acting vasodilators, if given continuously, they have no effect on exercise duration. Then what about the combining therapies? And these are the three major trials have been conducted looking at the combination therapy. You can see that if you combine an hemodynamic with two hemodynamic drugs, you have no benefits of the combined therapy, as shown by TBET, IMAGE, and CSER. This is more specifically the CSER trial, and you see that there was no difference between the addition of the calcium channel blocker to atenolol, and also when they looked at the effect on amlodipine or compared to atenolol or the combination, there was no difference whatsoever. Another way of looking at the ischemia is the effect on cardiac metabolism. We see that cardiac metabolism is very important, as up to 30 kilos of ATP are consumed daily by our heart, and the beats approximately 100,000 times per day. And the mitochondrial oxidation of the acetyl coenzyme I is very relevant because it's because it may improve the tolerance to ischemia. And if you look at the effect of drugs that block the beta oxidation, these are data from the VASCO study that looked at the effect of trimetazidine on top of atenolol, 50 milligrams. You can see that the addition of trimetazidine in these patients on atenolol improves exercise capacity and ST depression. What also was important from this study that showed that doubling the dose of trimetazidine was also more effective on symptoms and exercise capacity. So one approach is to use an hemodynamic agent with trimetazidine, but also we know that there is patients with myocardial ischemia tend to have a mechanical dysfunction of the late sodium currents, and ranolazine is a very potent drug that affects the electrical stability of the late sodium channels, and therefore avoids the calcium overload. It was been studied in 4 key randomized placebo-controlled trials: the MARISA in monotherapy, the CARISA in combination, ERICA combination with maximum dose of hemodynamic anti-anginal, and also in the Merlin Team 36 that was in chronic coronary syndrome. You can see that the 3 major trials against the beta blocker, the MARISA, demonstrated their dose-dependent effect on of renolazine on ischemia, trough, and peak. The CARISA demonstrated an progressive effect of renolazine at all the dosages we use today on all parameters of myocardial ischemia in patients receiving hemodynamic anti-anginal therapy. And the ERICA study demonstrated a significant reduction of angina and the nitroglycerin use in patients with ischemic heart disease, angina, that are also receiving an angina that were receiving hemodynamic agents. So the benefit of renolazine added on the fact that it has an effect on glycated hemoglobin, and this is another area of where the renolazine may have an edge because of the good effect on glycated hemoglobin, and that suggests that it may be a good indication for patients with diabetes, an effect that is similar to the one that has been reported by Fragasso for trimetazidine. So to conclude, I think it's important to understand that stable angina has multiple mechanisms. With PCI, we treat the fixed atherosclerotic narrowing, but we don't treat all the other causes of ischemia that may be the causes why patients after PCI continue to be symptomatic. And we also have to adapt our therapeutic approach according to the different type of patients, according to the different causes of angina, whether it's microvascular, in diabetes, in chronic kidney disease, and peripheral arterial disease, but also according to what has been proposed, according to the heart rate and blood pressure, as hemodynamic agents may or may not fully been tolerated by patients, and therefore the use of PCI plus a lower dose therapy may be effective. So in conclusion, since the advent of the PCI in 1977, the treatment of coronary artery disease has been mostly anatomically driven. I always tell my students the ocular stenotic effect. So you see it, you want to dilate. So there's no doubt that PCI is life-saving in patients with STEMI and STEMI, but the effect of in patients with STEMI shouldn't be translated to patients with chronic arterial disease, and optimal medical therapy is effective in all patients, and we should not look at the PCI and medical therapy as antagonistic, but basically they should concur in treating the best our patients. I'll stop here and I'll be happy to take your questions.
Thanks, Doctor. So, it's a privilege to have you with us today, Doctor. It was an excellent conference. I have some questions. The first one, given that this topic is still widely debated, as you presented, in your view, how would you define a complete optimal medical therapy? If only it includes the management of angina, or maybe it's something more.
Yeah, I mean, we have to understand that these, I mean, nor the PCI, nor the any medical therapy, beta blockers, calcium channel blockers, nitrates, ranolazine or trimetazidine has any effect on prognosis. The prognosis of medical therapy is given by the antiplatelets, by the lipid-lowering and ACE inhibitors. So the full medical therapy should include these three classes of drugs, and for angina, the treatment with an hemodynamic, ideally, as I tried to explain towards the end, of one hemodynamic agent with one or two non-hemodynamic agents. Because if you combine the two hemodynamic agents, you're not going to see any benefit. I mean, very often we see patients that are taking, say, a beta blocker and a nitrate. I mean, what was the point? I mean, there's no additional benefit of chronic nitrates in patients who are adequately fully beta blocked, but there's a benefit of taking trimetazidine or ranolazine on top of a beta blocker because they have additive effects. So I think we should start with the three preventative therapies plus the drugs that are better and they're best tolerated by our patients. I mean, if I have a young male patient, I'm not going to use a beta blocker unless there is an indication for heart failure or left ventricular dysfunction. So I think we should take a personalized approach, and the personalized approach should be always pursued in all our patients.
Thanks, doctor. The Dr. Clara Sardariaga has a question.
So thank you, Jorge. It's really nice and a privilege to have you today with us, Dr. Rosano. Thank you for your wonderful presentation. I just have a question. So it's very clear that the therapy is really important in chronic coronary syndromes, but can you mention something about those high-risk anatomies that were not included in trials like ischemia? Those patients that, for the characteristics of the coronary arteries anatomy, like proximal LID, or when the disease is in the main, if those patients apply to that, or we consider to be more invasive and treat those high-risk lesions?
Yeah, no, I think that in those patients, I mean, thank you for your question. You're always straight to the point. And I mean, we see patients with, say, proximal say left main or proximal LAD and proximal circumflex. And in that case, we don't have a clear answer on whether the PCI does any better, because in that case, our approach should be PCI or surgery. And surgery in patients with more diffuse disease works better. And the only question that is open is still is for patients with, say, proximal LAD and in between PCI and CABG, where probably they are similar, although the data are very old and there were data for open heart surgery. We don't have data with minimal invasive Lima to LAD. But I think that is the only area that is a sort of a gray area. In all other patients, I think in those with who are more complex, I think that there is an edge and the benefit of CABG over PCI. And of course, in those patients with increased surgical risk, then PCI is the option, because there are many patients who have an increased surgical risk where we cannot just risk to have them asleep, and we need to take the PCI approach. And for those, there is a clear indication for PCI.
Thank you very much. It was really nice to see you and to hear
this. As always. Look forward to seeing you soon.
Thanks, doctor. Doctor, a professor from our university asked Dr. Carlos José Jaramillo and Domingo, what is the role of exercise-based rehabilitation programs in the management of stable angina?
Exercise rehabilitation is crucial in all patients with ischemic heart disease. There was a study was conducted in 2012 in Germany, where patients were randomized to receive either either PCI or undergoing rehabilitation. Rehabilitation was even more effective in improving the degree of ischemia and the overall well-being. So wherever possible, cardiac rehabilitation is the best way to approach our patients, not just because of the benefit of the exercise, but also because of the fact that patients are kept on more under observation and therefore they are adequately up-titrated.
Thanks. I have another questions on the chat. It's in relation to the use of CMR previous to the CAT to like improve the choice or the decision to evaluate the ischemia areas. What do you think about the use of cardiac resonance on this scenario?
I think that any functional test that can tell us how extensive is the myocardium at risk is important. I mean, CMR is very good. It depends on the availability. And in my institute, it's very easy to perform. And CMR, possibly, it's easier. We can have a quicker CMR than a stress echo, but the stress echo is equally effective, and thallium scintigraphy is equally effective. So I think we should apply those methods according to whatever is available to our places.
Thanks, Doctor. I have, for my part, a last question about this. Dr. Rosano, regarding asymptomatic patient in our daily practice, we often see cases where coronary CT angiography or coronary angiography is requested without a clear indication, sometimes because the patient goes to our routine checkups or due to oversight. Then the patient revealed significant coronary artery obstructions, leading to a referral for a cardiology consultations. How do you manage such cases, and what measures do you implement in the medical field to reduce the occurrence of unnecessary diagnosis tests?
Basically, you don't need, if a patient is asymptomatic, there's no need to do any test that is anatomically, only anatomic. Because if you perform a test that is anatomic, then you have what I said earlier, the oculostenotic effect. You see something, you have to dilate. And it's always difficult to explain patients why you're doing it. So I think in patients with ischemic heart disease, on patients with angina, or patients who had angina and then are treated and they're asymptomatic and they're well treated, there's no reason to perform that. Probably a functional test is more important because it can tell us whether there's been a progression, and especially if the patient is active. If the patient is not active, then I would change. I mean, let's say you have a patient with significant peripheral arterial disease, patients with arthritic pain, patients who cannot exercise, where we don't know what is the ischemic threshold, then in that case, probably functional test is useful.
Thanks, Doctor. Maybe a last question on the chat. What do you think about inflammatory therapy? It will be some scenarios, it will be a choice of something.
I mean, anti-inflammatories has demonstrated a benefit. Of course, there are patients with chronic inflammatory syndromes where probably that anti-inflammatory, the colchicine, is very effective. The problem with colchicine is the tolerability, because it's 40 to 50% of patients that have gastrointestinal problems. So but if you can get those patients where they may tolerate it, then you have to use, you can use it. But you have to use the correct dose, because if you use a homeopathic dose, then you don't get any benefit.
Thanks, Doctor. So, Doctor, at the moment, there are no more questions. I don't know if you would like to keep some last words.
I mean, it's been a pleasure to be with you, and I look forward to be there to be with you in person sometime in the future. Will be of course more pleasant, and also to be with friends that I see on the screen. And
Doctor, so ladies and gentlemen, as we conclude this enlightening session, I want to send our deepest gratitude to Dr. Giuseppe Rosano for his invaluable contributions and for sharing his profound knowledge on this important subject. On behalf of the cardiology program at the University of Antioquia, thank you once again for your time and dedication, Dr. Rosano. Wishing you all the best in your future. Goodbye and stay well.
thank you very much. Thanks a lot. Bye to all. Bye.